Hi there, my name is Katja Kovacic. I'm an associate professor of pediatric GI at Children's Wisconsin and Medical College of Wisconsin. I'm going to bring to you the physician introduction to nausea and vomiting, talking about functional and motility causes of nausea and vomiting, and the complexity of diagnosis and management, and trying to bring up some of the controversies that we face with these disorders. So I'm going to bring up a quick patient case. This is a 16-year-old female with daily abdominal pain and constant nausea. She wakes up every day with abdominal discomfort. It's worse with food intake, and she has a lot of bloating, early satiety, and fullness with eating. So meaning that every time she eats, she takes a few bites, feels really full, and really cannot eat much. And therefore, she's had progressive weight loss, over 40 pounds over the last 2 years. It's been a very chronic, ongoing, disabling issue. Being evaluated by numerous subspecialists. She also has regurgitation and heartburn. And so there's been no diagnosis for all these issues. And outside of the GI tract, she also has symptoms. So she complains of postural dizziness, so a lot of symptoms when she stands up, chronic joint pains, chronic fatigue, insomnia, and some brain fog, so difficulties concentrating, can't sleep. So these are clearly very disabling symptoms. And she does not have a diagnosis. She was diagnosed, like clear diagnosis, she was diagnosed with a functional GI disorder and likely anxiety. But guess what? Her psychology evaluation shows that she does not meet the criteria for a generalized anxiety disorder. So something's not fitting, right? So what are functional GI disorders? The newest name and more appropriate name is disorders of gut-brain interaction. What I'm going to talk mostly about is functional nausea and vomiting disorders, and sort of bring the controversy surrounding these up. And I can't talk about everything. I'm going to focus on few. So functional nausea and functional vomiting is kind of one of the categories. And cyclic vomiting is another one, cyclic vomiting syndrome. Rumination and aerophagia are also grouped into these type of functional GI disorders. So what is functional nausea? So the definition per Rome 4 criteria, and these are the criteria that are expert consensus guidelines that define these syndromes, because we don't have a test, we don't have diagnostic test to say that that this is what you suffer from. So these are experts sitting together and deciding at their best of their knowledge what the criteria should be. So the thought is that predominant symptom of bothersome nausea at least 2 times per week, that's generally not associated with meals or vomiting. So just as severe nausea, no other explanation for it. That's thought to be functional nausea. And they further specify that the absence of pain suggests that they should not be included as part of functional dyspepsia. Now, what's functional dyspepsia? Well, that's a different category of chronic functional abdominal pain disorder, which we're not going to talk most about pain today, but I want to bring this up because functional dyspepsia, those patients have severe nausea. It's part of the diagnostic criteria. They have nausea and they may vomit. So studies show that these patients may have a stiff, non-relaxing stomach. We call it a non-compliant stomach. These are Barrowstedt studies where a balloon is stuck down into adult patients' stomachs, and they found them to be kind of stiff. So there's something wrong there, right? And those patients suffer from severe nausea. They have meal-related nausea and sometimes vomiting. So they're not part of those functional nausea disorders, but they do still have nausea. Well, that's a problem, perhaps. Another entity that closely overlaps with functional dyspepsia is called gastroparesis. This has delayed gastric emptying. And this crazy complex picture is just to show that how many mechanisms goes into emptying your stomach. There's nerve innervations from the brain. There's potential that can be abnormal. The autonomic innervation, autonomic nervous system innervation of the stomach, and how that signaling is affecting the stomach emptying is very important. There could be decrease or abnormal specific called the nitric oxide synthase neurons. These are specific neurons that can be abnormal in the stomach mucosa. There's stomach works as a pacemaker actually, and that activity of those pacemaker cells can be abnormal, and you can have what's called gastric dysrhythmia, similar to the heart. And then there could be abnormal coordination with all these function and the mixing and coordination of different parts of the stomach that can cause a delayed stomach emptying. So stomach physiology is very complicated, and we don't understand or have a good test to capture all these different things. Now, gastroparesis overlaps greatly with this functional dyspepsia, and gastroparesis patients suffer from severe nausea and vomiting. One of the most predominant features of gastroparesis is nausea, severe nausea, especially with eating. If they vomit, they may occur later in the course of after eating, compared to functional dyspepsia, maybe be a little sooner after eating, but they're very difficult to distinguish by symptoms, okay? So physicians have a hard time figuring this out. And the gastroparesis diagnosis, just to add to the difficulties here, there is a test where you eat a radio-labeled meal, and that meal should empty from the stomach within about 2 hours. 4 hours. If after 4 hours, 10% or more of the meal is still sitting in the stomach, that's called delayed. Okay, this is based on adult criteria. Taking a bunch of healthy adults in pediatrics, which I work in. We don't have any norms. So we go by adult norms for an adolescent who may have very different emptying pattern of their stomach, very different values. Age, gender, body mass index, drugs taken, medications, the menstrual cycle, hormones, how your sugar control functions, all these things play into stomach emptying. So this is simply not a good test. We know that from in adults even, there's day-to-day variability how that test works. So we have a test that doesn't tell us the true story. When the test is normal, we are told, we tell the patients that you don't have it, but can we trust that? When the test is abnormal, we tell the patient you probably have it, but can we trust it? Can we see how this complicates the picture? Yes, it does. An inadequate test that doesn't capture the spectrum of disease may not be very sensitive to capture everything, that every abnormality is actually potentially causing a worse picture, right? So patients are left with no diagnosis from a vomiting or a diagnosis that we're not sure about. Who knows? This is the intricacies of functional GI disorders. There's all this overlap between different types of disorders: gastroparesis, functional dyspepsia, anxiety comes into play, irritable bowel syndrome may kind of overlap, and patients may be diagnosed with heartburn because they regurgitate things. Things are not emptying from the stomach doesn't function properly. Is it stiff? Is it not emptying? What's going on? Well, it's not coming out of the stomach, then it's regurgitating back, and your diagnosis may be gastroesophageal reflux disease. So we tend to throw all kinds of diagnoses at patients when there's just, when there is an overlap of a lot of physiologic factors. We're trying to label patients, we're trying to separate it into boxes when it may not really be possible with our current knowledge. So functional GI disorders is a composite of many complicating factors. It's your genetic makeup, your genetic predisposition, maybe most likely your microbiome setup, early life events, trauma, stressful events, prematurity may implicate early exposure to drugs, to allergies. There's a lot of potential in factors that come into play that sets you up for functional GI disorders. Then there's all these external factors that come into play later and may bring the disorder out, including traumatic events, peer relationship, your sleep, everything kind of in your organism inside and out plays into functional GI disorders. Now, we have this whole glob of psychiatrics overlay. So anxiety, depressions, emotion, how you react, your emotional reactivity to your symptoms and how you cope with them appears to be a large factor in many patients, if not most. The complicating issue then is that as physicians, we often pull that out too much and we blame it on a psychiatric and mental health issue, when that may be part of the picture but may not be the driving factors. There's a lot of stigma surrounding this. Patients are labeled with anxiety, depression, and that could be almost a consequence of the initial problem and not finding a diagnosis. What is the role of psychiatric disorder? We really have no clue. In my opinion, we don't know. I wanted to bring up this controversy to discussion as we don't know if it's the chicken or the egg. Anxiety certainly is prevalent. Anxiety, stressors certainly impacts the brain gut disorders here. The more stressed you are, the more stressed out you are, the more anxious you are, the worse your symptoms are going to be. But is it the underlying thing? When is it? We really don't know. So People have studied these in adults. People have studied these chronic unexplained nausea and vomiting patients. There's a nice Gastroparesis big registry of many hundreds of patients, adults with suffer from these symptoms. And they found that patients who have normal stomach emptying, the gastric emptying, are actually very indistinguishable for those who have delayed emptying. So that makes it even harder. What's going on? We can't distinguish them. They have simply not been very well characterized. We don't know if these patients form a separate entity or some undiagnosed gastric motor dysfunction, something wrong with the motor function of the stomach or the sensory and motor function of the stomach. So how can physiology inform us? We need more research. We need to better understand the underlying physiology from research and develop better tests. And I want to briefly bring up another complicating factor is the autonomic nervous system innervate the stomach and the upper GI tract and most of the GI tract. And this is formed by the parasympathetic and the sympathetic nervous system. These are a very simplistic way of looking at it, but this could underlie many functional GI disorders. We don't know how many, all, none, a spectrum of them, but sometimes patients develop really severe symptoms of autonomic imbalance, and the most common one is called Postural Tachycardia syndrome. People suffer from dizziness, orthostatic when you stand up, lightheadedness, chronic fatigue, concentrating issues, severe nausea. Nausea and vomiting is very prevalent in autonomic disorders. We call them dysautonomia. It's a global big buzzword. There is recent data from adults that links autonomic nervous system or ANS dysfunction with chronic nausea and delayed stomach emptying. Prior to this, we didn't really know. We didn't really have any correlations. Now there's some emerging data. We still don't know. Remember, we still don't have a good test. So how do we study things when we don't have a good test? But the study in particular found that parasympathetic dysfunction is part of the autonomic nervous system that handles rest and digest. That's associated with delayed stomach emptying and more severe symptoms. So there's something here, and more data needs to be coming. Another syndrome to complicate these things is a connective tissue disorder where people have joint hypermobility. It's called Ehlers-Danlos Syndrome, strongly associated with functional GI disorders and autonomic dysfunction, dysautonomia. This could be an underlying disorder in some, but many patients, many individuals who are normal and healthy seem to have joint hypermobility. So this further complicates things and further wants us to label patients and put them in different boxes where it may not be possible. And I want to briefly talk about cyclic vomiting syndrome. This is vomiting attacks that occur in episodes of nausea and vomiting, disabling episodes that last maybe a few hours to several days. 10 days is unusual, but thought to be the upper spectrum. They occur at least 1 week apart. They're very stereotypical. So they're migraine disorders and have similar triggers to migraines. And you vomit multiple times per hour, and then you turn into baseline health again. Here we look at as extensive overlap again between CVS, cyclic vomiting syndrome, and abdominal migraine and migraine headaches. So this is a bucket of disorders that are cousins of each other. They overlap, their features are very similar, and misdiagnoses are common. Some of them actually have a diagnosis of gastroparesis or delayed stomach emptying because they vomit. They get treated with a lot of different variety of medications, and too many medications, too many drugs to treat them, and the difficulties figuring out what people suffer from can sometimes lead to polypharmacy. But predominant symptom that if you have headache or if you have vomiting or if you have belly pain, the most predominant symptoms is what defines the illness, to try to clinically separate the two. No testing for these disorders are existent either. Unfortunately, the autonomic dysfunction I mentioned actually overlaps with cyclic vomiting. So, and we have just found this data that to put it simple, the parasympathetic nervous system, which is called the vagus nerve, and the vagal function is actually reduced in children with CVS. We haven't published this yet, but it's very interesting to see that patients with CVS and the orange here are markedly reduced in their vagal nerve function compared to healthy controls. This has been shown a little bit before in both adult and CV and children, but this is some new data that's pretty solid and shows that there's an interesting tie here. So these are very interrelated disorders that manifest with nausea and vomiting. Patients with autonomic dysfunction have a lot of nausea and vomiting. We've actually shown, and this is also unpublished data, that a third of children with cyclic vomiting as young develop through chronic autonomic nervous dysfunction in adolescents. They suffer from severe chronic nausea. So that's why I want to bring this up, as this is a new findings, not even published yet, not replicated, but I feel that there's a strong population here of where the dysautonomia or autonomic nervous system imbalance are sort of sitting there and have not been really thought too much about or studied yet. And we need to focus a little bit more about what's going on in these patients with chronic nausea and not just call them anxiety. Okay, how do we know when psychiatric disease do drive the symptoms? Or we don't, but we need to build trust with our patients. We need to see them frequently and follow up. We need to get to know them. We need to continue to search for answers, but still be mindful of the escalating anxiety when you do more medical workup. You need to be careful with polypharmacy and too many drugs to try to fix things. Then many times these disorders are not fixable. So consider other psychological mindfulness therapies that do help because they reduce stress. And we have new non-invasive neuromodulation therapies on the rise, and we need to continue our research efforts to figure out these disorders. So in summary, there's a great overlap between functional GI and motility disorders. Separating and labeling patients may not really be very helpful. Understanding complexity and pathophysiology is key to treating patients. And autonomic dysfunction may really play an essential role in many disorders. I wanted to bring this up at one of my key points, how this fuses into many of these disorders, and there's some emerging data, but we don't know enough. These disorders are very difficult to separate from psychiatric disorders. Sometimes that's a small part, sometimes a large part, and there's a spectrum here where we need to figure out what's really going on, but we need more data before we can label patients correctly. So there's still hope, and that's all I wanted to say. Thank you very much for listening, and on to some discussions.